right, thank you, Jeff. Good morning, everyone. So I'm sure all of you have had patients you've either put on PPI or had them on PPI, and with like 2 minutes left in the clinic visit, they say, well, I heard that PPIs are bad because of X. So we're going to talk about all the X's and Y's associated with PPIs today. So I'm going to talk about PPIs just briefly in general, and then the safety concerns, and then we'll talk about the alternatives to PPIs, which is always a big question in patients' minds. So just a brief comparison of all the different PPIs, and this is, we'll say, the mid-level dose. I have the different PPIs at the bottom, and the intragastric pH suppression is pretty good and comparable among all PPIs. So I just want to point that out in terms of overall efficacy. You really can't go wrong with one versus the other. But what's the matter with PPIs? Well, unless you've lived in a cave and don't listen to CNN or other news media outlets, PPIs have been linked to impaired mineral absorption and various consequences, such as with regard to calcium and magnesium, kidney disease, cardiovascular disease, certain infections, and then most recently, dementia. So I want to start with a case to get your brains working if still getting used to the time change. We have a 55-year-old woman, and these are real cases that I'm going to discuss with you, who has hypertension, and she has a known osteopenia by bone density scan from 2 years ago. She also has had reflux for 10 years. At the time of her diagnosis, she had an EGD that showed a 4-centimeter hiatal hernia and Los Angeles Class C erosive esophagitis. On follow-up EGD after starting on a PPI, she had confirmed healing of the esophagitis, and her symptoms have been well controlled with twice-daily omeprazole. However, recently she's heard from her friends that PPIs cause osteoporosis. In her history, she does smoke a half pack of cigarettes a day and has been doing so for about 30 years. She tried stopping omeprazole based on this new information from her friends, but the heartburn came back very quickly. And even when she tried to cut down to the once-a-day dosing, she still had heartburn. So my question for you is, what would you recommend to this lady to treat her reflux and address her concerns? A, tell her that the studies are retrospective and therefore invalid. B, stop smoking and continue the PPI. C, take calcium citrate and continue the PPI. D, switch to an H2 blocker. Or E, refer to for hiatal hernia repair and fundoplication. Okay, so the majority of you said to stop smoking and continue PPI. I'm not going to get into what may be or may not be the right answer, but I agree that I would have picked that, especially from the stopping smoking standpoint. Okay, so we'll come back to this case in the end, but let's talk about the issues with calcium. So in general, calcium requires an acidic environment to be ionized and improve solubility. Now, just in terms of the different calcium preparations, calcium carbonate, which is probably the most common calcium preparation, its soluble is proportional to the acidity. However, calcium citrate does not require an acidic environment. Its absorption is independent of pH. So the thought is that if you have hypochlorhydria due to PPIs, it reduces calcium absorption, reduces bone mineral density, and therefore increases the risk of fractures. Now, there really have not been any high-quality studies to show that PPIs actually inhibit calcium absorption. The studies have been quite poor in terms of showing this association. However, because of those initial poor quality findings, the FDA actually issued a warning for PPIs because of this potential risk of osteoporosis and fractures. So there have been a lot of conflicting results over the years, and we're talking over a decade of studies looking into this. So early reports that linked PPIs to hip fractures, they were all case control studies. And so they had a low magnitude strength of association, and they were open to a lot of bias. And probably the one that best highlights these issues was the Nurses' Health Study that included over about 80,000 subjects. And they found that the odds ratio for hip fractures was greater than 1, and the confidence interval was above 1. However, when they accounted for smoking, the confidence interval crossed 1, and therefore it was an insignificant association. There have been other studies that have shown no association, and then more recently there was a large Canadian study. It was kind of interesting. So they actually took the PPI users and non-PPI users and they followed them out over about 10 years. Now at baseline, the group of PPI users had a lower bone mineral density score. It's not clear how long they were taking PPIs for to begin with. However, when they followed them out at 5 and 10 years, there was no change in the rate of bone mineral density loss across the two groups. So in a sense, it's hard to determine why ongoing use of the PPI would not lead to an accelerated bone mineral density loss, yet at the beginning there was a lower bone mineral density in the PPI group. So the point here is that it's not very clear. So for each of these issues, I'm going to try to come down with the bottom line, at least from my take in reviewing the literature. There really is no strong evidence that PPIs actually have an increased risk for accelerated bone mineral density loss. And really, PPIs should not be discontinued if they're being used for the appropriate indication. Of course, you want to try and use the lowest dose that's going to be effective to control symptoms. And then there's the issue of calcium supplementation. Well, this is already a controversial issue. When it came to calcium supplementation and improving bone mineral density, studies several years back actually showed that it did not improve BMD. However, if we're thinking that the proposed mechanism is that PPIs reducing the acidity affects calcium solubility, then you could consider having patients take calcium citrate, which would bypass that mechanism. Okay, now we'll get into the second case. We have an 84-year-old gentleman who has had heartburn for about 30 years, or it started 30 years ago, excuse me. Currently, he's on one of the PPIs, high dose, with good control of his symptoms. Previously, he had been taking 20 years of omeprazole once or twice a day, and he had an endoscopy about 5 years ago while he was on a PPI, and it showed no evidence of esophageal mucosal damage. However, his wife recently heard that there was a study showing that PPIs increased the risk of kidney disease, and so now he's worried he's causing problems to his kidneys. So what do you tell him? Check his GFR. If it's normal, continue the PPI. Or B, stop the PPI. The literature on this subject is indisputable. C, send him for surgery. D, switch to an H2 blocker. Or E, just tell him stop reading about these medical studies. It only causes confusion. All right. So I agree with you all on this one for choice A. So let's talk a little bit about kidney disease. So it is known that PPIs do have a risk of acute interstitial nephritis. It's thought to be an idiosyncratic reaction, but it's been proposed that persistent persistent exposure to PPIs in a sense causes this low-grade acute interstitial nephritis that can lead to fibrosis, chronic kidney disease, and even end-stage renal disease requiring dialysis. So how significant is this risk? This study came out last year. It was a large VA study, and it compared patients to PPIs, on PPIs versus H2 blockers. That was considered the baseline. And when they calculated hazard ratios, it was compared to those who were taking H2 blockers. So you can see that for all the different measures on the left, looking at different ways of assessing chronic kidney disease, the hazard ratio was significant. Confidence interval was started greater than 1. But when you look at the absolute risk versus the H2 blockers, even with end-stage renal disease, where I remember seeing the article saying CNN reports 96% increased risk of end-stage renal disease, the absolute risk increase was 0.1%. So it depends on how the statistic gets spun in terms of the significance of this risk. There have been other studies that have shown similar hazard ratios. This risk probably is real. It's just the magnitude of it may be overstated. I thought that this was a very telling graph. So maybe it's a little hard to see the legend on the right, but again, looking at chronic kidney disease in different forms, whether it's a change in the GFR, doubling of the serum creatinine, need for dialysis, and so forth. But as you can tell, the graph, all of the markers, they go up until about 2 years, and then it looks like the risk seems to decrease. So it may be that there's something about chronic use, but up to a certain point after which there may not be added risk. So it looks like the risk of chronic kidney disease is real, but it probably is overstated. It might be worthwhile checking serum creatinine. There's no guideline recommending this, and so we don't know if there's an appropriate frequency for checking and also for how long. And again, as I mentioned, the risk might be significant up until about 2 years based on that study I pointed out. So it might be reassuring for patients that if they have a normal GFR beyond 2 years of treatment, that the PPI probably is not going to cause them a problem with their kidneys. Okay, moving on to magnesium. PPIs might inhibit intestinal absorption of magnesium. There have been about 50 case reports in the literature of severe hypomagnesemia that did not improve with oral magnesium supplementation, and it only improved when they received IV mag or discontinued the PPIs. And this risk seems to be exacerbated by using a loop diuretic such as furosemide, because that leads to renal wasting of magnesium. But going beyond these case reports, there have been studies looking at the general population and magnesium levels. So PPI use seems to have reduced the magnesium level. The average absolute reduction was about 0.02 milliequivalents per liter, which is actually quite small, since if you look at the lab, it actually only goes to 1/10 of the decimal point. The effect does seem to be compounded by using a loop diuretic at the same time, where it dropped it by 0.07. And then the odds ratio was about 2 for increased drop, or for a drop in the magnesium level to what's considered hypomagnesemia, and was much worse even with concomitant loop diuretic use. Now, interestingly, H2 blockers also seem to have a similar reduction in the magnesium level, but this doesn't get worse with loop diuretics. And then there was also this managed care cohort that looked at patients who were on PPIs for more than 6 months, and about 57 had low magnesium level, but only 8 of them, or 2%, could they not attribute it to another cause, and so they presumed that it was from PPI use. And in these patients, the magnesium level was low, but again, it wasn't profoundly low. So this risk, while it is real, it doesn't seem to be quite significant, both in terms of how common it is and also how severe it is. So just to summarize with hypomagnesemia, the risk appears to be low, the reduction is small, worse with loop diuretics, and seems to be worse with chronic use. And then how to monitor these patients, it makes sense to check a magnesium level at baseline and then after 6 months. And a mild decrease probably doesn't require any intervention or discontinuation. However, if there's a significant drop, or of course if they develop symptoms of profound weakness, you probably want to check this and then consider the PPI as contributing to this. And in these patients, an H2 blocker may or may not actually be suitable as an alternative. Okay. Cardiovascular disease. So it's been known for a while that PPIs, by way of their metabolism, can compete with clopidogrel. And because clopidogrel is a prodrug that needs to be metabolized into its active form, if you have PPI competitive inhibition, then its potential to make the clopidogrel less effective and lead to cardiovascular and thrombotic events is there. But additionally, this goes to some of the more recent studies that have been highlighted in the lay press, there may be an effect on endothelial cell function. Now, in mice, PPIs were shown to increase a level of this endothelial nitric oxide synthase antagonist called ADMA. However, it's been a little bit more conflicting in humans, and most studies seem to suggest that it actually doesn't seem, or PPIs don't seem to increase this ADMA level in humans. And then there was a study that actually looked at flow-mediated vasodilation, and PPI use did not seem to impair this in humans. Now, looking at more clinical studies, there was a systematic review that looked at PPIs in dual antiplatelet therapy. Now, originally it was thought that maybe this interaction with clopidogrel was limited more to omeprazole and esomeprazole, but in this systematic review, they found that really all PPIs did seem to be associated with an increased risk of cardiovascular events. However, all these studies were observational, so there were multiple confounders present. Another study looked at PPIs and aspirin and found that there was no increased risk for cardiovascular events. And then the more recent study, which again gathered a lot of attention but had its limitations, looked at PPIs and myocardial infarction in the general population. And with PPI use, there was a slight increased risk that was considered significant for heart attack. However, and these are author-stated limitations, and when we look at the author's own reports of limitations, they tend to be very superficial. But here they note that it was an observational study and that other factors affecting these patients that put them at risk for cardiovascular disease may have been more likely, and the PPIs just kind of got dragged in. But they also didn't account for things like obesity and insulin resistance, which with diabetes being an equivalent heart disease risk factor, that really creates a lot of confusion, and I think that really dampens the quality of the study. Yet this is something that patients bring the article or the news report in about, and so it makes it difficult for us to try to overcome that. So I think with regard to cardiovascular risk and PPIs, the biggest concern is the use of PPIs with clopidogrel. However, the data is conflicting, and actually both GI and cardiology societies recommend that PPIs be continued in patients on clopidogrel who are at high risk for upper GI bleeding. So it really comes down to what's the indication for being on the PPI. And then the risk of just cardiovascular events in the general population is really not well substantiated. So we just kind of have to point out to our patients that the data that are out there right now are really of low quality, and so it's hard to make a good assessment on that. All right, dementia. That's been the most recent thing, and of course very scary for everyone, both young and old. And really the data that are out there right now just come from two studies from the same authors, and they were both based on German health insurance database queries. And they found that in the studies, it was about a 1.4 hazard ratio for dementia with chronic PPI use. Now, I reviewed these studies, and really it was a prescription database query in terms of whether or not the patients were considered to be taking PPIs. They identified numerous confounders, and actually when they accounted for these, the hazard ratios went up, which again was a little bit confusing. Now, the mechanisms that have been proposed for dementia mainly come from mouse studies, and so there seems to be increased beta amyloid levels in the brain after these mice are treated with PPIs. And some PPIs have been shown to cross the blood-brain barrier, and it's thought that if you inhibit the lysosomes in the microglia, this can prevent or reduce the acidity and prevent degradation of these beta amyloid proteins that can then accumulate in the cells. This has the least, has been the, well, it's the newest thing, so it hasn't been as well studied. And so my bottom line here is we really don't know right now. And so there's a lot of concern, understandably, but it's we have to be careful about getting into a panic about this based on two retrospective studies that had limitations. So truly further research is needed, and right now I'd say it's difficult to justify stopping a PPI based on this concern, especially in someone who's benefiting from the PPI. A couple issues on infections. So pneumonia, the strongest association with PPI use seems to be in short-term use, so less than 30 days. There doesn't seem to be any association with chronic use. And there's a lot of heterogeneity in the studies that makes it difficult to explain why this is the case. With C. diff, it's thought that acid inhibition may allow the spores to take a vegetative form. And there were early studies that showed that there was an increased risk of C. diff infections in both H2 blockers and PPIs. More recently, there have been larger studies that didn't show an association, and multi-society studies, including infectious disease societies, do not recommend discontinuing PPIs to prevent C. diff. So let's talk about briefly alternatives to PPIs. So patients want to take ranitidine or famotidine, just something else that hasn't been studied so much in these risk categories. So they might have a lesser risk or no association for various conditions, but because they're not used so commonly, they're not as well assessed now. And at least with the magnesium issue, there seems to be just as much risk. But we know overall they are less effective for controlling GERD compared to PPIs, and also for healing erosive esophagitis. And then there's also this concept of tolerance for chronic use in that it only blocks the histamine pathway. So then patients ask about surgery, or when they say, well, what are my options? I mean, I'm going to bring up surgery just so that they have a full spectrum of what's available. So not to belabor this point, but it is an option for long-term GERD control, and it's been shown to be as effective for medical therapy. The best outcomes, as Jeff kind of alluded to, are those who have the typical symptoms and those who respond to PPI. And these patients do require a preoperative evaluation, so make sure that they are adequate candidates and not that they have something else going on. Two main options at this point in time are the fundoplication and the sphincter augmentation. Just so that you see schematics of these surgeries. Really the two on the left, the Nissen and the toupee, are the ones that are used. The door is used as part of the Heller myotomy for achalasia. I think we're all familiar with the postoperative complications, but patients need to know that these surgeries are not perfect. There's gas bloating, there's early and sometimes late dysphagia, diarrhea, flatulence, and not all patients will be able to come off of their PPIs. Sphincter augmentation increases the LES tone. It's placed laparoscopically. It seems to be better in the sense that it does not lead to as much of the inability to belch or vomit that the fundoplication has, but the dysphagia does tend to be more problematic. So just to finish up, follow up on these patients. So with case number 1, so we talked about the potential mechanism of PPIs and calcium issues. We talked about the limitations of the study. So really it's about having a conversation with your patients and explaining the data behind it. I encouraged her to stop smoking, of course. We talked about surgery, and she felt that that was the right thing for her, especially since the PPI helped her so well. And she had the large hiatal hernia. And so right now she's awaiting surgery. In my older gentleman who had chronic kidney disease, again, we talked about the potential mechanism and the risk based on the studies. I checked his GFR, and it looked great. And so I told him that, hey, look, you've been on this for over 25 years. I don't think you're going to get kidney disease. And so he accepted that, but still wanted to get his GFR checked every 6 months. Whether or not that's really necessary is anyone's guess right now. But that's how things work. So what I tell my patients in general, if the PPI is helping you, then to me the benefit outweighs the risk. And the risk right now, I have to say, is controversial. Of course, if the PPI is not helping, why take a medicine that's not providing benefit? And maybe there's a risk. I think pretty obvious. Again, try to find the lowest effective dose that works for these patients. And then, I talk with them about surgery, especially those who respond to the PPI or have persistent reflux despite it, so again, requires appropriate testing. However, I think at this time we should not let the fear of these potential risks associated with chronic PPI use drive the need for surgery or drive getting surgery. And then finally, you have to remind these patients that surgery just isn't as good as new. With that, I thank you very much.